Welcome to Pediatric Case Review. Today we present a comprehensive case-based review of Osgood-Schlatter disease, designed for general pediatric physicians. This lecture covers clinical presentation, physical examination findings, pathophysiology, diagnostic imaging, differential diagnosis, treatment strategies, long-term sequelae, and complications. We will work through 15 carefully crafted clinical cases to sharpen your diagnostic and management skills. Let us begin. Case 1. A 13-year-old male soccer player presents with progressive right knee pain over the past 6 weeks. The pain intensifies during sprinting and jumping, but improves with rest. He denies any history of trauma. On physical examination, there is localized tenderness directly over the tibial tubercle with a palpable bony prominence. Which of the following is the most likely diagnosis? Option A, patellar tendinitis. Option B, Osgood-Schlatter disease. Option C, Sinding-Larsen-Johansson syndrome. Option D, tibial stress fracture. The correct answer is option B, Osgood-Schlatter disease. Osgood-Schlatter disease is characterized by repetitive traction on the tibial tubercle apophysis in growing athletes. The classic clinical presentation includes insidious onset of anterior knee pain, exacerbation with activity, and point tenderness directly at the tibial tubercle. This pattern perfectly matches this condition. Patellar tendinitis causes pain in the tendon itself rather than the bony prominence. Sinding-Larsen-Johansson syndrome causes pain at the inferior pole of the patella, not the tibial tubercle. Tibial stress fractures would have a different distribution of pain and would typically follow a sudden increase in training load. Case 2. Initial diagnostic approach. A 12-year-old girl reports bilateral knee pain that worsens when climbing stairs or sitting for long periods. She plays volleyball and has recently increased her training intensity. Physical examination reveals bilateral tender bony prominences just below the kneecaps. What is the most appropriate initial diagnostic approach? Option A, magnetic resonance imaging of both knees. Option B, plain radiographs of both knees. Option C, blood tests including complete blood count, erythrocyte sedimentation rate, and C-reactive protein. Option D, ultrasound of the patellar tendon. The correct answer is option B, plain radiographs of both knees. While the diagnosis of Osgood-Schlatter disease is primarily clinical, plain radiographs are the appropriate first-line imaging. They confirm tibial tubercle fragmentation and enlargement, demonstrate soft tissue swelling around the tubercle, rule out fractures and other bony pathology, and are cost-effective and readily available. Bilateral imaging allows direct comparison between both sides. Magnetic resonance imaging is reserved for refractory or atypical cases. Blood tests are useful when infection or inflammatory arthritis is suspected, but not in this classic presentation. Ultrasound is useful for early soft tissue changes, but is not the standard first-line investigation. Case 3. Physical examination maneuvers. A 14-year-old boy complains of pain when extending his knee against resistance during a sports physical. On examination, you note a firm, tender bump just below the kneecap. He has no fever or systemic symptoms. Which of the following maneuvers best confirms the diagnosis? Option A, McMurray test. Option B, Lachman test. Option C, resisted knee extension test. Option D, Apley scratch test. The correct answer is option C, the resisted knee extension test. Pain on resisted knee extension is pathognomonic for Osgood-Schlatter disease. When the patient extends the knee against resistance, tension is transmitted through the quadriceps muscle to the patellar tendon, which directly stresses the inflamed tibial tubercle insertion point and reproduces the characteristic pain. The McMurray test assesses meniscal pathology, not apophyseal injury. The Lachman test evaluates anterior cruciate ligament integrity. The Apley scratch test is used for shoulder range of motion assessment and has no role in knee diagnosis. Case 4. Characteristic physical signs. A 13-year-old male basketball player is evaluated for left knee pain. On examination, you observe a prominent, tender mass below the patella. He also has tight quadriceps and hamstrings. Which of the following physical findings is most consistent with Osgood-Schlatter disease? Option A, positive anterior drawer sign. Option B, tenderness over the medial joint line. Option C, enlarged tibial tubercle with pain on palpation. Option D, hyperextension of the knee at rest. The correct answer is option C, enlarged tibial tubercle with pain on palpation. The presence of an enlarged, tender tibial tubercle is pathognomonic for Osgood-Schlatter disease. The tibial tubercle becomes prominent due to repeated traction injury, reactive bone formation, and partial avulsion of the apophysis. Tightness in the quadriceps and hamstrings is a contributing factor that increases traction forces on the tibial tubercle. A positive anterior drawer sign would indicate anterior cruciate ligament injury. Medial joint line tenderness suggests meniscal pathology. Hyperextension at rest is not a feature of Osgood-Schlatter disease. Case 5. Biomechanical pathophysiology. A 12-year-old boy presents during a recent growth spurt with localized anterior knee pain that developed after starting intensive football training. The pain is specifically located at the tibial tubercle and worsens with running and jumping activities. What is the underlying biomechanical mechanism responsible for the development of Osgood-Schlatter disease? Option A. Increased femoral anteversion causing abnormal tracking. Option B. Repetitive traction on the tibial tubercle apophysis. Option C. Congenital dysplasia of the patellofemoral joint. Option D. Avulsion of the medial collateral ligament attachment. The correct answer is option B. Repetitive traction on the tibial tubercle apophysis. During rapid skeletal growth, the tibial tubercle remains cartilaginous and more vulnerable to traction forces transmitted through the strong quadriceps muscle via the patellar tendon. With repetitive high-impact activities such as running and jumping, these traction forces cause microfractures at the apophysis. The resulting inflammatory response leads to pain, swelling, and reactive new bone formation, eventually producing the characteristic bony prominence. This process is significantly accelerated during growth spurts when the tibial tubercle is at its most vulnerable developmental stage. Case 6. Developmental stages. A 13-year-old male basketball player presents to your clinic with a 2-month history of right knee pain. The pain began gradually during his growth spurt and intensifies during jumping activities. Physical examination reveals tenderness and swelling over the tibial tubercle. You suspect Osgood-Schlatter disease and want to explain the underlying developmental anatomy to his parents. Which of the following best describes the developmental stage of the tibial tubercle in this 13-year-old boy? Option A. Fully ossified epiphysis that has fused with the tibia. Option B. Secondary ossification center that is still forming. Option C. Primary ossification center that is mature. Option D. Cartilaginous structure with no ossification present. The correct answer is option B. Secondary ossification center that is still forming. During adolescence, typically between ages 11 and 14, the tibial tubercle exists as a cartilaginous secondary ossification center. This developmental stage makes it particularly vulnerable to repetitive traction forces from the patellar tendon. The cartilaginous structure is softer and more susceptible to injury than mature bone. The growth spurt during this period increases mechanical stress on the developing bone significantly. Fusion of the tibial tubercle with the main tibial shaft typically occurs between ages 14 and 18 years, after which the risk of Osgood-Schlatter disease effectively disappears. Case 7. Diagnostic workup for persistent pain. A 14-year-old male soccer player presents with persistent right knee pain that has continued for 4 months despite adequate rest, activity modification, and physiotherapy. Initial plain radiographs 3 months ago showed fragmentation of the tibial tubercle with soft tissue swelling. The patient reports that pain persists during daily activities and prevents return to sports. Physical examination reveals continued tenderness over an enlarged tibial tubercle with no signs of infection. What is the most appropriate next step in the diagnostic workup? Option A. Magnetic resonance imaging of the knee. Option B. Bone scan using scintigraphy. Option C. Computed tomography scan of the tibia. Option D. Diagnostic arthroscopy. The correct answer is option A. Magnetic resonance imaging of the knee. Magnetic resonance imaging is the gold standard for refractory cases of Osgood-Schlatter disease. It is the most sensitive imaging modality for detecting persistent inflammation in this condition. It can detect early bone marrow edema before radiographic changes appear, evaluate soft tissue inflammation and tendon thickening, and guide treatment decisions in chronic cases. It is considered essential when symptoms persist beyond 3 months of conservative care. An important clinical point: magnetic resonance imaging can detect inflammatory changes weeks before plain radiographs show bony abnormalities, making it invaluable in refractory or diagnostically uncertain cases. Case 8. Early detection sensitivity. A 12-year-old girl presents with bilateral knee pain that worsens when climbing stairs or sitting for long periods. She plays volleyball and has recently increased her training intensity. Physical examination reveals bilateral tender bony prominences just below the kneecaps. Plain radiographs of both knees appear completely normal. Which imaging modality would be most sensitive for early detection of Osgood-Schlatter disease in this patient? Option A. Ultrasound of the patellar tendons. Option B. magnetic resonance imaging of both knees. Option C, computed tomography scan with contrast enhancement. Option D, bone scintigraphy using a nuclear scan. The correct answer is option A, ultrasound of the patellar tendons. Ultrasound is highly sensitive for detecting early soft tissue changes in Osgood-Schlatter disease when plain radiographs are still completely normal. It can identify thickening of the distal patellar tendon, hypoechoic soft tissue swelling, and bustle effusion often preceding any visible bony changes on X-ray. Key advantages of ultrasound include the ability to detect tendon thickening before radiographic changes appear, demonstrate soft tissue swelling and inflammation, provide dynamic assessment during movement, and offer a non-invasive and cost-effective evaluation. This makes it an excellent first choice when early diagnosis is needed and radiographs are unremarkable. Case 9. Differential diagnosis, Part 1. A 13-year-old boy presents with anterior knee pain that has been bothering him for 3 weeks. He is an active basketball player who practices 4 times per week. Physical examination reveals point tenderness specifically at the inferior pole of the patella, not at the tibial tubercle. There is no history of direct trauma to the knee. The pain worsens with jumping and improves with rest. No swelling or warmth is noted. Which condition is most likely? Option A, Osgood-Schlatter disease. Option B, Sinding-Larsen-Johansson syndrome. Option C, jumper's knee, also known as patellar tendinitis. Option D, osteomyelitis. The correct answer is option B, Sinding-Larsen-Johansson syndrome. Sinding-Larsen-Johansson syndrome is a traction apophysitis affecting the inferior pole of the patella, commonly seen in active adolescents during growth spurts. The critical distinguishing feature is the pain location, just below the patella at its inferior pole, which is distinctly different from Osgood-Schlatter disease where pain is at the tibial tubercle, lower down on the leg. Both conditions share similar risk factors, including young athletic patients and activity-related pain. The absence of trauma and the activity-related pattern with rest improvement support the diagnosis of traction apophysitis rather than patellar tendinitis or osteomyelitis. Case 10. Differential diagnosis, Part 2. A 15-year-old male basketball player presents with persistent right knee pain for 4 months. There is no history of acute trauma or direct injury. Pain worsens with jumping and running activities. He was initially managed with rest and nonsteroidal anti-inflammatory drugs with only partial improvement. Physical examination reveals a tender, enlarged tibial tubercle with a palpable bony prominence and no joint effusion or ligamentous laxity. Plain radiographs reveal a large, mobile bony fragment at the tibial tubercle insertion site. What is the most likely diagnosis? Option A, tibial tubercle avulsion fracture. Option B, osteochondroma of the proximal tibia. Option C, Osgood-Schlatter disease with unresolved ossicle. Option D, stress fracture of the tibial tubercle. The correct answer is option C, Osgood-Schlatter disease with unresolved ossicle. Mobile bony fragments identified in the context of a non-traumatic history are characteristic of unresolved Osgood-Schlatter disease. This occurs when partial avulsion of the tibial tubercle apophysis fails to heal completely, resulting in free ossicle formation at the insertion site. The key distinguishing feature from a traumatic avulsion fracture is the complete absence of an acute injury history. This free ossicle represents incomplete healing of repetitive microtrauma that occurred during the adolescent growth spurt. Osteochondromas are typically found away from tendon insertions and have a characteristic radiographic appearance. Stress fractures would show a different radiographic pattern without the characteristic ossicle at the tibial tubercle. Case 11. Treatment and activity modification. A 13-year-old boy with Osgood-Schlatter disease has moderate pain during sports activities. His symptoms improve significantly with rest between games. The pain is manageable and does not interfere with daily activities. His parents are concerned about his continued participation in basketball and ask for guidance. What is the most appropriate recommendation regarding his sports participation? Option A, complete cessation of all sports activities until symptoms fully resolve. Option B, continue sports participation but limit to low-impact activities only. Option C, return to full unrestricted sports activities immediately. Option D, use a knee brace and continue playing without any modifications. The correct answer is option B, continue sports participation but limit to low-impact activities only. Activity modification is the cornerstone of Osgood-Schlatter disease management. Patients should continue sports participation while avoiding high-impact activities that exacerbate tibial tubercle stress. Complete activity cessation is unnecessary and may lead to deconditioning and loss of fitness. The recommended conservative approach includes applying ice after activities to reduce inflammation, using nonsteroidal anti-inflammatory drugs for pain control, implementing a dedicated quadriceps stretching program, and planning a gradual return to full activity as symptoms allow. This balanced approach maintains physical fitness while allowing the apophysis time to heal. Case 12. Refractory management. A 14-year-old girl presents with bilateral Osgood-Schlatter disease. Despite 3 months of activity modification, rest periods, ice therapy, and regular stretching exercises, she continues to experience significant pain during basketball practice. Physical examination reveals persistent tenderness and prominent enlargement of both tibial tubercles. Her coach is asking when she can return to competitive play. What is the most appropriate next step in management? Option A. Prescribe oral corticosteroids for inflammation. Option B. Begin formal physical therapy with eccentric strengthening. Option C. Recommend immediate surgical consultation. Option D. Advise complete sports cessation until age 18. The correct answer is Option B. Begin formal physical therapy with eccentric strengthening. When conservative measures fail after 3 months, formal physical therapy becomes the essential next step. Eccentric loading exercises are specifically designed to strengthen the quadriceps while simultaneously reducing patellar tendon stress. The mechanism of benefit includes promoting tendon healing through controlled mechanical stress, improving muscle strength and endurance, and reducing pain through neuroplastic adaptation. Neuromuscular retraining also improves lower limb biomechanics, reducing excessive traction forces on the tibial tubercle and helping to prevent recurrence. Oral corticosteroids are not indicated and may impair tissue healing. Surgery is reserved for rare cases with persistent ossicles in skeletally mature patients. Case 13. Long-term sequelae. A 20-year-old man presents to your clinic with recurrent knee pain and a palpable bump below his kneecap. He mentions having knee problems during his teenage years while playing soccer, and his mother recalls a doctor diagnosing him with growing pains in his knee around age 13. The patient now experiences occasional discomfort during physical activities and when kneeling. What is the most likely long-term outcome of his childhood condition? Option A. Complete resolution with no residual symptoms. Option B. Development of patellofemoral osteoarthritis. Option C. Persistent pain and bony prominence. Option D. Risk of tibial tubercle fracture. The correct answer is Option C. Persistent pain and bony prominence. While the majority of patients, approximately 90%, experience complete resolution of symptoms with skeletal maturity, up to 10% of patients may experience persistent symptoms into adulthood. A prominent tibial tubercle is a common long-term finding and is usually asymptomatic, though it may cause cosmetic concern. Chronic pain can occur if the osseous fragment remains mobile rather than fusing completely. The condition typically resolves naturally once the growth plate fuses and the tibial tubercle ossifies completely. Residual bony changes are frequently observed on imaging even in asymptomatic adults who had childhood Osgood-Schlatter disease. Activities involving direct pressure on the tibial tubercle, such as kneeling, may remain uncomfortable. Case 14. Rare complications. A 16-year-old athlete is being counseled about potential long-term outcomes of his Osgood-Schlatter disease. His parents are concerned about future complications and ask about what problems might persist into adulthood. Which of the following is not a recognized complication associated with Osgood-Schlatter disease? Option A. Tibia valgum deformity. Option B. Recurrent bursitis. Option C. Growth arrest of the tibia. Option D. Patella alta. The correct answer is Option C. Growth arrest of the tibia. Growth arrest of the tibia is not a recognized complication of Osgood-Schlatter disease. This is because the tibial tubercle apophysis is anatomically separate from the main proximal tibial growth plate. Osgood-Schlatter disease affects only the secondary ossification center of the tibial tubercle, while the primary growth plate remains completely unaffected by the traction forces involved. There are no documented cases of growth disturbance reported in the literature. The actual recognized long-term associations include persistent bony prominence at the tibial tubercle, patella alta, which means a high-riding patella, increased posterior tibial slope, and recurrent bursitis at the tibial tubercle. These are important to counsel families about when managing this condition. Case 15. Radiographic features. A 14-year-old male basketball player presents with a 4-month history of anterior knee pain that worsens with activity. Physical examination reveals a prominent, tender bony mass at the tibial tubercle. Plain radiographs are obtained to confirm the diagnosis and assess disease progression. Which radiographic feature is most commonly seen in the late stages of Osgood-Schlatter disease? Option A. Joint space narrowing of the tibiofemoral compartment. Option B. Sclerosis and irregularity of the tibial tubercle. Option C. osteolytic lesions in the proximal tibia. Option D, soft tissue calcification around the patella. The correct answer is option B, sclerosis and irregularity of the tibial tubercle. Fragmentation and sclerosis of the tibial tubercle are the pathognomonic radiographic findings in Osgood-Schlatter disease. These changes represent the chronic traction injury and the healing response at the apophyseal insertion site. Key imaging hallmarks include tibial tubercle fragmentation with irregular ossification, sclerotic changes indicating a chronic stress response, soft tissue swelling anterior to the tubercle, possible loose ossicles in chronic cases, and an enlarged tibial tubercle prominence. An important clinical point, radiographic changes may persist into adulthood even after symptoms have fully resolved, so radiographic findings should always be interpreted alongside the clinical picture. We would like to take a moment to introduce you to the Pediatric Case Review community. This is a dedicated learning platform where all lecture videos are carefully organized by medical system, covering cardiovascular, respiratory, musculoskeletal, neurological, endocrine, and many more topics. This means you can access every video you need in one place without searching across multiple platforms. In addition to the videos, all presentation slides used in the lectures are available as downloadable photos, so you can read through the content and practice all the clinical questions at your own pace. High-quality medical images and multiple-choice questions are also included for each topic. If you would like to join the community and find out how to subscribe, simply comment below this post, and we will message you directly with all the details. We have now completed our comprehensive case-based review of Osgood-Schlatter disease. We covered 15 clinical cases addressing clinical presentation, examination findings including the resisted knee extension test, biomechanical pathophysiology, developmental anatomy of the tibial tubercle apophysis, diagnostic imaging including the roles of plain radiographs, ultrasound, and magnetic resonance imaging, differential diagnosis including Sinding-Larsen-Johansson syndrome, conservative and refractory management, and long-term complications. If you found this lecture helpful, please follow Pediatric Case Review for more expert-led comprehensive case reviews. If you have any questions about Osgood-Schlatter disease or any other pediatric condition, leave them in the comments below and we will provide detailed answers for you.